Good morning, good afternoon, and good evening. Welcome. Bonjour et bonsoir. Soyez de la bienvenue. As we arrive, I invite you to share your affiliation, your location, and what gives you hope today. And we'll get started very shortly. So once more, good morning, welcome, good evening, bonjour, bienvenue. My name is Rachel Dessum. I'm from the Global Health Division of Chemonics International. I'm the Technical Director of the Usaid Financed Human Resources for Health, or HRH 2030 program. Thanks to all for joining our HSR 2020 satellite session today. Building a resilient health system by improving data-driven health workforce decisions, evidence, and approaches from Asia and West Africa. We're here today because it's impossible to reimagine health systems for better health and social justice without a diverse, resilient, well-protected health workforce for all. It is people who drive health systems, from the minister all the way down to the frontline health workers seeking to reach the underserved. Today, let us honor the thousands of health workers who have made great sacrifices during this pandemic. Let us commit to supporting them 1 million health worker shortfall worldwide in too many contexts, whether during crises or throughout routine decision-making. Planners and policymakers do not have a clear picture of health workers to know how many they have, nor their location, their employment status, nor their latest qualifications. The Chemonics-led HRH 2030 program envisions a health labor market where all health workers can pursue career opportunities and thrive to improve the health of their communities and nations. Much remains to be done to build, manage, and optimize the health workforce and the social service workforce to promote decent employment, to address gender inequity, support, sustain, and retain the existing health workforce, optimize care delivery, and ultimately achieve health for all. So what kinds of data-driven health workforce decisions do we need to improve health system resilience? What kinds of information systems are needed, including how to figure out what the best skills mix is for health work to support health workers who are on the front lines? Lending from Crook et al.'s seminal article on resilience and lessons learned from Ebola, we can consider how health systems resilience can be defined in terms of how aware it is, how diverse it is, how self-regulating, how integrated, and how adaptive. Chemonics International and our collaborators are pleased to engage you during today's session. Our esteemed contributors from around the globe, their experiences, best practices, lessons learned, and tools that have contributed to strengthening the health workforce, whether in fragile contexts, in mixed systems, or at the community levels. So we'll start with some opening remarks from the Office of Health Systems at USAID. Then our first round will focus on improving evidence-based planning and policy making. So, what workforce evidence is needed to inform national high-level decisions that determine policies and long-term approaches for universal primary health care? We'll learn from the Philippines' experience using data and the national health workforce accounts to adapt and integrate health workforce strategies within the national policy rollout. And how can country governments work in a multisectoral manner to capture the often disparate data sources from across the health labor market? We'll learn from Indonesia's experience making investments to improve the diversity and the quality of human resources information across the health labor market in order to identify rapid awareness of the workforce and identify effective redeployment strategies in response to COVID-19. Our second round will focus on applying strategic data for health workforce optimization, including at the subnational level. What management capacity is needed to better deploy, support, and optimize the health workforce? We'll learn from how Senegal has implemented capacity building approaches to better self-regulate and operationalize health workforce policies. And on the front lines, what evidence can empower facility and health managers to act with data to optimize and support the existing workforce? We'll learn from Molly's efforts to use adaptive tools at the facility and community levels to improve the accessibility and quality of care for essential services and to diversify through task sharing. And finally, we'll engage you and our contributors in an interactive case study on how to take action with health workforce data and improve health system resilience. We hope that you've familiarized yourself with using the HSR platform. During the Q&A at the end of each round, we'll be responding to questions, so please type them in the live Q&A. And we encourage your active participation in the discussion. French, and we'll also be posting resources there. So I'm now very pleased to introduce Ms. Kelly Saldana, Director of the Office of Health Systems in the Bureau for Global Health at Usaid, who will be providing us with opening remarks. Over to you, Ms. Kelly.
Thank you, Rachel. Good morning, good afternoon, good evening to everyone joining us from around the world. Thank you for your participation in this session. And I also want to thank the HRH 2030 Project for organizing this session and to the other guest speakers for sharing their experiences today. COVID-19 has had profound implications for USAID's mission and operations. With regard to the health workforce, the global health community has been alarmed by the threat posed to COVID-19 to health workers around the world. In Africa, for example, WHO reports that more than 44,000 infections in the health workforce so far, which is a sign of the challenges that staff on the front lines of the outbreak face. As the pandemic continues, the risks to health workers may grow. COVID-19 cases have the ability to strain health facilities and reduce available health worker time to respond to routine and other essential health services. This severe strain on the health workforce is amplified due to limited facility readiness and the global shortage of health workers. During these challenging times, events such as this HSR conference provide an important channel for constructive dialogue and for exchanging ideas, particularly those that identify ways to optimize already strained resources. Data-driven health workforce planning is important now more than ever. Perhaps if there's one positive thing to come from 2020, it's that coronavirus has highlighted the critical importance of the global health workforce and the need for all countries to examine how their health system can do a better job of supporting a sustainable health workforce. We know we need to examine and understand local systems as a first step in identifying the possible solutions to existing challenges within the health workforce. In these times, technology becomes even more important to enable capacity building at the national and local levels of the health system and to share experiences such as in platforms like this. This year, USAID launched a Digital Development Awards program to recognize USAID missions, bureaus, and partners that are supporting countries to become self-reliant in a digital age. The awards celebrate USAID-funded projects and activities that use digital technology to sustain open, secure, and inclusive digital ecosystems in order to improve measurable development and humanitarian assistance outcomes. I am thrilled to recognize that USAID's HRH 2030 program, implemented by Chemonics International, has won the USAID 2020 Digital Development Award for its work in Indonesia. HRH 2030 works with national partners to strengthen the human resources for health information system and its ecosystem to provide real-time quality data for strategic use, while also supporting policy development that addresses challenges in the health workforce. This is a great example of how investments in the health workforce and optimization of information systems proved crucial for supporting health workers during COVID-19. The Indonesian Ministry of Health was able to develop and rapidly deploy data dashboards on the health workforce for making decisions during response planning. I look forward to hearing more from HRH 2030's Indonesia team on their work today. Clearly, a health system's ability to maintain delivery of quality essential services in the current environment depends on how effectively and flexibly it can deploy resources to where they are needed most. Countries will need to balance the demands of responding directly to COVID-19 while maintaining the integrity of existing health sector priorities and preventing backsliding of progress towards achieving universal health coverage goals, and also while mitigating the risk of health systems collapse. As USAID works to support countries around the world to build resilient health systems that are accountable, affordable, accessible, and reliable, we understand that these objectives cannot be achieved without a strong health workforce. USAID has demonstrated a long-standing commitment to human resources for health. We have supported countries to develop and strengthen the health workforce to be more equally distributed and accessible to the population, better prepared and responsive to emerging threats, and we also work to ensure that health workers have the skills and motivation to deliver acceptable care. We also promote investments in and access to high-quality data to enable country leaders to make more informed decisions. Data can help countries remain flexible and adjust resources as needed so that the health system is responsive to new and emerging challenges like COVID-19 while maintaining essential healthcare. The ability to adapt to changing health needs and allocate resources accordingly before, during, and after a health crisis is a hallmark of health system resilience. Thus, in terms of overall health systems resilience, the data-driven health workforce decisions are critical. For example, health labor market information can enable better workforce allocation and investments such as training the right numbers and kinds of health workers who are needed now and in the future based on current and projected health needs. Data helps identify recruitment, deployment, and retention challenges that hinder service delivery, so health workers are where they are needed most and stay there. And national human resource information systems make data available for developing policies and budgets at the national level. Recently, USAID has completed a strategic review, which we call Over the Horizon, which was meant to ensure that the agency is positioned to achieve its goals across the development sector and implement its programs in a world altered by COVID-19. 6 health sector related recommendations came from this review and will inform our planning in the near future. And while broad, none of these recommendations can be achieved without a robust and comprehensive workforce, which covers a full set of capabilities across the health system. These recommendations are to 1, build health system resilience by strengthening capacities across public, private, faith-based, and community health sectors. 2, to protect US and global health security through a holistic approach, inclusive of community level health actors. 3, to invest in sustainable health financing and public financial management to improve health resilience and the accessibility and affordability of essential care. 4, to promote access to a safe, licensed vaccine against COVID-19 with a clear roadmap for its rollout. 5, to invest in and promote access to high-quality data to improve the ability to collect and share accurate information on COVID-19 so that appropriate interventions can be delivered. And 6, to support the ability of public and private health systems to address the prevention and response to gender-based violence. So as you can see, I think this is an extremely relevant session, which will provide lots of information, both learning from the past and really to enable the way forward. Because COVID-19 has had and will continue to have an extraordinary impact on the people, places, and partners to which USAID provides assistance. In light of this, the agency must prepare for the lasting changes to the development and humanitarian landscape in the medium to long term. A stronger, more diverse, responsive, and data-driven workforce can contribute to health system resilience and help countries reach and sustain their health goals. I look forward to hearing the specific examples and thoughts offered by the esteemed panelists on this important topic today. Thank you.
Thank you so much, Kelly. Most appreciated, and it's really exciting to see how there are some opportunities to make further investments in real-time health workforce data for more efficient and flexible resource allocation. Wonderful. I'll now pass it over to Mr. Kasum Diallo, who will be the moderator for round one, developing the pathway for improving evidence-based planning and policy making. Over to you, Mr. Kasum.
Thank you very much, Rachel, and thank you, Kelly, for the really great opening remarks. And I would like also to join Kelly to thank HRH 2030 for organizing this session. I think this session is absolutely relevant and critical in the days that we are facing this global pandemic around the COVID-19. And you both raised the issue about the central role of health workers in this COVID response. And most of the people are assessing this role from a health system perspective, but also looking at it from also the impact it is having on the health workers. And in assessing the impact, people tend to look at the infections and deaths, but the impact is much more than that, because you have to look at not only infection and death, but you have to look at also the stress, the burnout, the strikes that are resulting from poor working conditions, etc. So really, health workers are at the center of this response, and it's important that we continue to support them. Maybe you are part of those who used to stand in their windows and upload every 9 p.m. in the health workers. So I just wanted to reiterate really that the relevance of this topic, and in particular, the central role of data for decision making and how data can support this work. When you're looking at these issues, and in particular, when you look at it from a data perspective, you see that most of the countries are progressively using evidence-based decision making. This evidence-informed decision-making is really positioning the quality of data at the center of the work that they are doing. And that's why also when you are looking at to identify the human resources for health challenges, you really need to look at it from different perspectives, not only the policy issues, but also some of the other issues that impact on the productivity, availability, performance, distribution of the health workers, taking into account the public health threats that is central to understanding the resilience of the systems. So it's important that all these issues are not looked at from anecdotal or general information, but from supported by strong evidence for the decision making. Next, please. And that's why WHO is very pleased to be supporting this, this session, and also to highlight some of the central issues related to the health workforce account, National Health Workforce Account. And when we are talking about the National Health Workforce Account, you're talking about the umbrella under which we coordinate all the work around health workforce data. And when you look at it, we trying to call what something, some of the key principles as the DNA of the National Health Workforce Account. And one of the most important principles is that it is a system strengthening approach. System strengthening approach meaning that strengthening system to be able to routinely generate and use information rather than focusing on an ad hoc process through which you can always from time to time conduct surveys that are not only expensive, but quickly outdated. How do you strengthen the system is to bring countries at the center of this to bring different stakeholders. We know that health workforce data is not only something that is collected by the Ministry of Health alone, but different ministries. When you look at the health labor market framework, different ministries, including the Ministry of Education for the training, the production, the Ministry of Labor, different other ministries, Ministry of Finance, and all that. The other central principle and key issues that we think in the NHWA implementation is really the diversification of data sources. We tend to look at the routine HIS or HRIS. Many countries are implementing a DHIS2 process, but what is important is not to say, okay, I'm going to limit myself to X or Y source, but to try to identify most of the sources that could help you inform the decision and then triangulate the information. And this diversification of sources include looking at labor force surveys, population censuses, and etc. And it is important that also that we strengthen the partnership at national level for data collection and analysis and for capacity building, but also going on only beyond the data in a database, trying to analyze the data and use it for the decision making. And those are some of the principles that we believe should be the DNA of any system, in particular the. So the next slide now is which one also, please, next slide. Rachel.
Yes, I'm on strategic actions for addressing.
Okay. Yep. Yeah, it's just that to show that when you look at it from this perspective, you have to look at it for a more comprehensive perspective, not only data for data, but data to inform policies, but data also related to governance, and those issues are important. So I just wanted to stop here and introduce our two main presenters today, Dr. Ruth Politico, who will be presenting the example of the Philippines, and Dr. Taufik Stompul, who will be presenting the Indonesia case. I would like to invite Dr. Ruth for her presentation. Thank you.
Bonjour to all our participants. Today, I'd like to share with you the Philippine experience on multi-sectoral approach to improve data in the country. On multi-sectoral approach to improve health workforce data in the country. The Philippines, like many other countries, face problems in health workforce distribution, governance, and financing. The COVID-19 pandemic highlighted many of these issues, including the need for up-to-date, reliable HRH data for planning and policies. After all, resilient health systems heavily rely on the availability of competent health workforce. As you can see, we've been struggling on the limited capacity of health information systems to collect the data on where our health workers really are and where they are practicing. For health workforce data is also strong legislation. When the UHC law was passed in 2019, this mandated two lead agencies of the government accountable for health workforce regulation and management to establish a registry of health professionals in the country. This registry will contain a subset of the modules included in the National Health Workforce Accounts, specifically on the current number of health professionals and where they are practicing. This is in Module 1, or the Active Health Workforce Stock. Part of the process is determining data needs, identifying sources of data, and agreeing with stakeholders on the standard definitions of the variables that will be collected. As you can see, there are multiple sources of health workforce data, and grouping them according to the health labor market framework facilitated coordination between stakeholders. Among professionally active health workers, we focused our initial efforts on those practicing in the health sector. As you can see in the table on your right, this is the Mark one marked in yellow, we wanted to collect first how many of our licensed health workers are actually participating in the health services or in the health sector. These narrowed down our priority sources of data, and we're able to influence some of the systems in other agencies to incorporate data sets or data fields and disaggregation for HRH information. For example, some of them were able to add employment data in addition to the registration data. Because the health system in the Philippines has evolved, data flows vertically from subnational and local levels, in primary care facilities, district hospitals, provincial hospitals, to the central DOH. For example, local governments who is in charge of hiring and managing the health workers at primary care level of the districts and provincial levels are the ones deciding on the collection, maintenance of information, including the decision of how to process them. This can lead to difficulties not only in obtaining health workforce data, but also in influencing or impacting the overall management of HRH at subnational levels. Horizontally, we also get info from other national government agencies, as shown in the previous slide. And even inside the DOH, various information systems collect a subset of health workforce data, so the data governance is quite complicated. To address this governance issue, we built upon a strong multisectoral partnership with the HRH Network Philippines, composed of several national government agencies, non-government organizations, including ACTI, and forced data sharing agreements with some of the key sources of information among them. Recognizing, though, that data sharing agreements are not the end-all and be-all of improving health workforce data, we co-developed a governance and accountability framework with HRH 2030 that demonstrates shared governance between the national and local levels. This structure is not just for HRH data, but also for workforce planning as a whole. As such, the data needs for planning and policy are incorporated in the steps from planning, implementation, monitoring of health workforce strategies, utilizing existing partnership mechanisms and governance systems. As a result of these efforts, we promoted the use of data not only through data visualization, which you may be able to appreciate if you scan this QR code on HRH statistics, but in analyzing the data for prioritizing strategies. These are then used for the development of HRH policies and plans, specifically the master plan and policies for scholarship and return service agreements for human resources for health. During this pandemic, the health workforce data has been very helpful in assessing the gaps and projecting the number of health workers needed for COVID response. With the help of our colleagues in the field of research, we were able to provide estimates for health workforce requirements based on the number of health workers practicing in the health facilities, desired staffing for units handling COVID-19 cases, and this during the first wave of the public health emergency. Projections were then used to request for budget to hire additional health workers. Collecting essential health workforce data also contributed to the development of staffing standards at primary care levels and updating projections for UC requirements. In conclusion, what we learned from our experience is we have to view improving health workforce data in full circle. Data has to be available when and where it's needed. The appreciation of its use generates support from stakeholders to contribute, and their contributions can sustain progressive improvement of information on health workforce that is critical to building resilient health systems. That would be all for the Philippines. Thank you very much. Maraming salamat. Over.
Thank you very much, Dr. Ruth. I would like to invite now Mr. Taufik Sitompul for his presentation. Taufik, you have the floor.
Thank you, Dr. Kasum. Hello, everyone. My name is Taufik Sitompul, and I am ICT Manager with SRS 2030 Indonesia. Next, please. Rachel?
Yes, there might be a delay. I'm on issues with HRH data. Your first starting slide, are you able to see that now? Great.
Yeah. What are the challenges that Indonesia currently experiences. Indonesia is facing issue with the maldistribution, with overstaffing in urban areas and urban staffing in rural areas. In that condition, we are seeing production of certain type of health workers that do not align necessarily with population health needs. We are also seeking a lack of coordination of stakeholders within the health labor of markets. Challenges with the data have impacted to the ability of the government to respond to these issues. Especially, issues revolve around lacking completeness of accuracy of data and limited integration or interoperability between many information systems. In addition, data usually analyzed in silos, with health workforce data rarely combined with health services data, so we can better understand the workload health workers are facing. And we were seeing issue with poor presentation of data, limiting the ability of stakeholders to truly understand what the data was telling us to better inform policy and planning. However, in recent years, Indonesia has put a strong policy focus on health workforce, information system, and data use. Next slide, please. To address this issue, in light of the enabling policy environment, we took a comprehensive approach to increase data use to support the health workforce for resilient health system. One, strengthen the existing information system to improve accessibility and awareness of data. Second, develop interoperability concept and strategy to better integrate data from diverse stakeholders and information system. The third, improve the analysis through use of business intelligence to allow stakeholders to be adaptive and responsive to health needs. These three approaches, we were built on the foundation of governance and building of capacity of stakeholders to deliver to achieve a sustainability program. Well, let's look to it and how they contribute to developing a resilient health system. As we noted before, SRS data issue in Indonesia included incomplete and non-accessible data on the health workforce. Because of this, to build this digital ecosystem, we focus first of strengthen the central human resources information system, SES-DMK, and build a data warehouse for that. By increasing the functionality of SRIS through change the infrastructure and features, this lead to improved quality of data, and as well they exchange the data between internal and external systems, improving confidence in the system by decision makers. Having quality data is important, but if others cannot access, the decision-making process is still impacted. With the SRS data warehouse, stakeholders at the all level of the health system have access to aggregate multi-year data, and this data warehouse is used the national level to exchange data stakeholders and also by the regional level to develop dashboard and rapid analysis. Overall, this strengthening of information system lead to improve the accessibility and awareness of existing data as well as gap and areas for quality improvement in this data, increasing use of data by decision makers. Once we have a strong base of health workforce, for the active health workforce, we move towards engagement of the stakeholders in the health labor market for interoperability to really create this digital ecosystem. In Indonesia, The decision-making process is not only built by availability of diverse data, but also the developing relationship between diverse stakeholders, interestingly, building interoperability or exchange the data between information systems, supported the governance needed to build strong relationship between stakeholders, including regional and national levels. We started with the engaging stakeholders to define common issues and the data needed to respond. Then work collaborative to standardize data for the exchange, such as developing common definition for data standards. Based on this, the technical interoperability was built for the exchange of data between systems. And now we go to the next slide, talking about the dashboard and data analysis. After stressing system and building interoperability in this digital ecosystem, we move toward developing strong data analytics and data visualizations using business intelligence concept and technology. We are using Tableau and SS2. We built dashboard at the national level and regional level for that. Overall, it should be not. There's a lot of focus building in this digital ecosystem was not only about the strengthening of the information system, but also training, coaching, and mentoring to be adaptive and responsive to health system needs. This investment in both system and people operating these systems allow for fast action in COVID-19 response. At the beginning of the COVID pandemic in Indonesia in last March, the Directorate of Human Resources was able to rapidly develop SRS dashboard, comparing with the SRS to the COVID situation at the national level and regional level, as well as monitoring of implementations policy, such as we focus on incentive payments and inform agency response programs such as volunteer or the other laboratory program. Because the SRS Directorate took the time to learn and increase in their capacity, they were able to take ownership of the data and rapidly to use the data and to be adaptive to need of the COVID-19 response. And we have conclusions and many lessons learned from that process. Developing a digital ecosystems that contribute to resilient health system does not come without challenges, and we learn many more or a lot of through development of digital ecosystem of health workforce data. One, emphasis should be replaced on the process and not the product. We concerned about that. Strengthening of information systems should be focused on not only solving the problem today, but finding the new problem to solve. Engaging the right stakeholders from the beginning is very crucial, and it's very important to engage the stakeholders. And the last point, and capacity building is not just about a skill building, but we try and continue to confidence building. That's my presentation, and terima kasih. Over to Dr. Kasum.
Thank you very much, Taufik, and thank you, Dr. Root, for your presentations. I'm just looking at the time, and we have so far at least one question for Dr. Root. Dr. Root, please, the question is, with HRS composing the large portion of Minister of Health budget worldwide, what kind of evidence or argument helped the Philippine DOH to make a HRH investment? So what was the basis for HRH investment in the Philippines? If you can quickly.
I think in general, yeah. Thank you, Dr. Kasum. So the best case for investing in health workforce is how to optimize putting HRH at the center of universal healthcare. We banked on the saying that there is no health without health workers. So I think that was our best case. And we used some evidences like how many poor municipalities or geographically isolated areas remain doctorless or have very poor health services due to lack of health workers. So we used those rationale for making our case for investment in the health workforce. Thank you.
Thank you, Dr. Ruth. I just wanted to go back to Rachel, just in case there is one more question, or shall we move to the next? Rachel, to you.
Yes, so there was another question about how to, for Taufik. So a participant would like to know what kinds of quick wins have helped decision makers to rely more on the information within the SIS-DMCA, the IRIS. You know, sometimes there's some behavior change in trusting the data. Were there particular data points or dashboards that that in your observation really helped them to rely on the system more and more? Over.
Thanks, Rachel. So it's a good question, and behavior and data is very important. So that's why we elaborate and coordinate how they can coordinate between internally and strengthen the not only technicals, but we focus on to make them or confidence to self their own system. This is the importance, results.
Great, and we have one last question that is for both of you. Just a moment, here we go. Just in terms of the ways that you know, you could continue to advocate for these investments. What do you think are some of, you know, the key messages about health workforce and how they can reinforce health system resilience? What are messages that you would give? What research might be needed to continue to make those investments? Over.
Thank you. Can we have a 1 minute answer each, please? Dr. Ruth, want to start?
So I think, as I mentioned earlier, making the need for health services at the very poor municipalities makes a best case for HRH investment, especially if countries like us are moving towards achieving universal healthcare for the population. So it triggers a lot of researches, like doing a health labor market analysis is one. And the other one is determining the financial and non-financial incentives that are required to motivate the health workforce to be where they are needed. So I think those are things that are very important to highlight in generating support for investment for health workforce. Thank you, Dr. Kasum and Rachel.
Taufik?
Yeah, it's must be collaborate between many stakeholders and have same goals and equity to reach the good system.
Thank you. If I may add one thing, I think one of the central things that could help also is the joint ownership. If different agencies at national level work together around the data, they identify the gaps together, they can identify the priorities together. And then from there, it will be easier to market the needs for investment rather than one entity or one ministry alone working in isolation without bringing things together. So I just wanted to go back to Rachel. I think time is there. So I don't know if you have some additional things before we move to the next session. Thank you again.
Yes, thank you so much, Kasum, Dr. Ruth, and Taufik for your insights. So we'll now shift over to round 2. Donc encore bienvenue. We're going to move into French, but look in the discussion forum for translation in English of key points. Donc, pour notre discussion sur l'application de l'utilisation stratégique des données pour l'optimisation des personnels de santé, nous avons le vrai plaisir d'accueillir nos collègues, Madame Inde Kumba Tiamindour, chef de division à la direction des ressources humaines, ministère de la Santé et de l'Action sociale du Sénégal, ainsi que M. Sila Abdoulaye, gestionnaire de suivi, évaluation et recherche du programme HRH 2030 au Mali. Donc, bienvenue à vous deux et merci d'être avec nous. Donc, nous allons commencer d'abord au Sénégal. Bonsoir, Madame Kumba. Si nous pouvons activer le caméra pour Madame Kumba. Très bien, voilà. Donc, bonsoir.
Bonsoir.
Merci. Donc, dans votre rôle au ministère, vous avez mené plusieurs initiatives et politiques pour améliorer les ressources humaines pour la santé depuis des années. Donc, comment est-ce que vous aviez investi en ressources humaines pour la santé, RHS, et dans les systèmes d'informatique pour des ressources humaines pour la santé?
Merci Rachel, bonsoir ou bonjour pour certains, bonjour aux modérateurs, aux panélistes et également à l'ensemble des participants. Je crois, merci également de nous avoir donné l'opportunité de partager ces quelques mots pour ce panel. À l'instar des autres pays, le Sénégal est constamment donc, à la recherche d'une meilleure gestion des ressources humaines en santé. Et cette meilleure gestion donc, tend à améliorer le problème donc, partagé, surtout par rapport donc, à la répartition du personnel de santé dans des territoires, la mobilité, la rétention et autres. Avec le plan national de développement des ressources humaines en santé 2011-2018, il y avait un axe stratégique qui portait sur la modernisation du système de gestion des ressources humaines. Et c'est cet axe qui nous a amené à faire donc, plusieurs tentatives donc, de recherche de logiciels ou d'applications pour la GRH. Et c'est partant de cela que, suite à un partage d'expérience avec le Mali, donc un ancien Kimba Kamara qui était à la direction des ressources humaines du Mali, qui nous avait présenté le logiciel Iris à Tokyo lors d'une session de formation. Et c'est comme ça qu'on s'est intéressé sur le logiciel Irish. Et en 2014, nous avons démarré donc l'implémentation de Irish avec IntraHealth Usaid. Et l'implémentation avait démarré par la contextualisation du logiciel parce que nous savons que Irish est d'origine anglo-saxonne. Et il nous fallait nous tenir compte du contexte sénégalais, des réalités, parce que la gestion des ressources humaines au Sénégal est éparse. On a la partie carrière qui est gérée par le ministère de la fonction publique, la partie salaire donc, qui est gérée par le ministère des Finances, et nous, donc, l'utilisation qui est gérée donc, par le ministère de la Santé. Donc, vous voyez un peu donc, les différents contextes, le contexte sénégalais et le contexte anglo-saxon. Et à la suite, nous avons pu donc, travailler sur la sécurité des données parce que c'est des données personnelles, des informations personnelles qui sont dans la base et il fallait donc vraiment assurer cette sécurité. Et nous avons travaillé avec l'Agence de l'informatique de l'État, donc qui gère tous les aspects donc, sécuritaires des données nationales donc, au niveau du Sénégal. La définition des niveaux d'accès également avec la cellule informatique à la DRH donc, était une étape importante parce que l'approche qu'on a prise avec Irish, c'est de déconcentrer l'utilisation. Donc, au lieu que Irish soit au niveau central et qu'une personne ou deux personnes donc fassent la gestion. Nous avons pris l'option de déconcentrer, donc en mettant en place des points focaux au niveau des districts, des points focaux au niveau des régions, des points focaux également au niveau des établissements publics de santé communément appelés hôpitaux. Et c'est pourquoi c'est ce qui justifie la nomination également des points focaux au niveau des directions, parce qu'au niveau de nos directions nationales également, nous avons des représentants qui saisissent les informations, qui mettent à jour les bases de données et qui transmettent également les tableaux de bord. Plusieurs sessions de formation aussi ont été organisées avec les autorités, que ce soit les médecins-chefs de région, médecins-chefs de district, mais aussi les partenaires sociaux, parce qu'il fallait les impliquer donc dans le processus pour une meilleure appropriation. L'élaboration des outils également, nous avons élaboré beaucoup d'outils parce qu'il fallait, c'était un nouveau logiciel, donc il fallait élaborer le manuel des formateurs, par exemple, une feuille de route pour le passage à l'échelle, un guide d'utilisateur, donc les normes de saisie également, vraiment des astuces, tout ce qui devait aider aux fonctionnalités du logiciel. Et pour ce faire, je crois qu'il fallait un appui, une volonté politique manifeste des autorités des ministères de la Santé, ce que nous avons eu dès le début. Mais il fallait également un appui technique et financier des partenaires, donc tels que HRH 2030, qui nous appuie et qui nous a appuyé et continue de nous appuyer sur le logiciel. Et vraiment, donc, c'est cette volonté politique qui justifie que jusqu'à présent, nous utilisons le logiciel Irish et qu'il faille mettre à jour ces données parce que c'est une mise à jour permanente, parce qu'on a une forte mobilité du personnel des ressources humaines en santé au niveau du ministère de la Santé et que cette mise à jour donc, doit être permanente.
Merci beaucoup, Madame Kumba. C'est très impressionnant et nous voyons comment, depuis presque une décennie, cette volonté était en train de vraiment se bâtir la fondation pour des ressources, les données réelles des ressources humaines pour la santé. Donc, lors des chocs, comment est-ce que ces investissements avaient amélioré votre réponse à la COVID-19, par exemple?
Okay. En prenant l'exemple de la COVID-19, nous pouvons dire que nous avons utilisé au niveau du Sénégal, donc Irish, pour déterminer les gaps, la détermination donc, des besoins, parce qu'au Sénégal, nous avons actuellement avec la COVID élaboré ce qu'on appelle un plan d'investissement pour vraiment un système de santé résilient, surtout face vraiment à ces chocs tels que pour la COVID-19. C'est vraiment Irish, donc avec l'existant, nous a permis donc de planifier tout ce qui est besoin, tout ce qui est recrutement, avec le PIS. Donc, on a vraiment utilisé Irish donc, pour ces données. Nous avons également utilisé les données de Irish pour identifier les points focaux qui avaient des difficultés ou bien même les responsables qui avaient des difficultés par rapport à la mise à jour pendant cette période parce que les supervisions étaient impossibles. Donc, avec la plateforme Zoom, par exemple, donc on a utilisé Irish Zoom donc pour continuer les renforcements de capacité, pour continuer également la mise à jour des données. Et le plus important, je crois que lors de cette période, c'est le partenariat que nous avions développé, le ministère de la Santé donc, et Orange. Parce qu'avec les données qui sont dans Irish, pour chaque agent, tous les agents enregistrés, nous avons un numéro de téléphone. Donc, un contact téléphonique qui a permis au ministère de la Santé, via Orange, d'envoyer donc des messages. Donc, des messages qui tournaient autour de la sensibilisation sur la conduite à tenir par rapport à cette maladie, l'exemple du lavage des mains, l'utilisation de solutions hydroalcooliques, mais aussi comment organiser l'ère de consultation. Donc, comment vraiment la distanciation à respecter. Donc, pour tout ce qui portait donc à la protection du personnel, mais aussi à assurer la protection de nos usagers qui étaient obligés, malgré cette pandémie, donc, de fréquenter nos structures. C'est ce partenariat Orange, vraiment ministère de la Santé, via les données de Irish qui nous a beaucoup marqué.
Merci, Madame Kumba. Donc, pour la mise en œuvre de IRIS, quelles sont les compétences nécessaires pour les acteurs au niveau sous-national, dans les régions et dans les districts?
Étant donné que Irish est un logiciel, donc la première compétence, c'est vraiment des compétences en informatique. Il fallait que les utilisateurs, que ce soit les administrateurs, les utilisateurs, aient des compétences en informatique. Donc c'était vraiment prioritaire pour faciliter la fonctionnalité du logiciel. Et les points focaux au niveau régional également, même si on avait certains médecins, nous avons principalement des secrétaires ou bien des superviseurs donc, qui travaillent tous les jours avec l'outil informatique. Donc, c'est pourquoi cette compétence n'était pas difficile à trouver donc, au niveau local. Et il y a également des compétences en gestion des ressources humaines, parce que c'est un logiciel donc GRH, mais ces compétences étaient beaucoup plus remarquables chez les chefs de service donc, des ressources humaines des hôpitaux, parce que c'est vraiment des responsables RH qui sont là, qui utilisent l'outil informatique, mais également qui travaillent sur l'aspect donc RH. Et ils nous ont beaucoup aidés dans vraiment l'implémentation lorsqu'il fallait paramétrer le logiciel, parce qu'en tenant compte des réalités de l'hôpital, mais également en tenant compte des spécificités des régions médicales et des districts. Et beaucoup de paramètres donc, ont été visités, raison pour laquelle nous avons mis donc l'harmonisation des cartographies des métiers, parce qu'il y a plusieurs catégories socio-professionnelles, plusieurs métiers qu'on rencontre et qui sont différents d'une structure à une autre. Donc, il fallait harmoniser et surtout les points focaux des hôpitaux nous ont beaucoup aidés dans l'harmonisation de ces métiers.
Merci beaucoup. Et donc, nous voyons tous ces investissements aussi dans le renforcement de capacité des acteurs pour l'utilisation. Donc, après cet investissement, les astuces comme vous aviez partagées, comment est-ce que ces acteurs s'informent pour les prises de décisions bien éclairées sur les RHS dans le quotidien et pour des tâches routines? Nous parlons beaucoup de l'utilisation des systèmes d'information donc quotidien et dans le routine. Merci.
Je crois que suite aux formations, que ce soit les points focaux, que ce soit également les décideurs, donc ils ont des compétences donc, sur le traitement et l'utilisation de données, parce qu'il y a des sessions de renforcement de capacité sur la qualité, l'utilisation donc, des données. Et sur la base de ça, ces responsables pouvaient visualiser à temps réel donc, les rapports. Donc, ils avaient également la possibilité d'extraire ces rapports, donc d'extraire des tableaux de bord qui leur permettaient de prendre une décision sur la base donc, des évidences, donc sur la base, par exemple, de la publication de l'annuaire des ressources humaines, qui comporte beaucoup de tableaux de bord et beaucoup d'informations sur les ressources humaines. Je prends l'exemple des sages-femmes avec la problématique de la santé mère-enfant. Nous avons eu, avec la coopération japonaise, initié ce qu'on appelle le couplet gagnant. Donc, couplet gagnant, il fallait assurer la disponibilité d'un infirmier et d'une sage-femme dans tous les postes de santé. Maintenant, avec Irish, donc, on peut visualiser tous les postes vacants, les postes de santé qui avaient soit un infirmier ou qui n'en avaient pas, ou bien qui n'avaient pas de sage-femme. On pouvait, avec Irish, donc, visualiser l'ensemble des postes vacants et ainsi, donc, pouvoir dire que voici le besoin dans chaque région, dans chaque district. Donc, ça, c'est un exemple donc, pour vraiment assurer tout ce qui est offrir des prestations de soins essentiels, tant pour la santé de la mère, mais également pour la lutte contre les maladies telles que la tuberculose, le paludisme, et au niveau donc, des postes de santé. Il fallait donc intégrer l'utilisation de données ressources humaines dans la planification et les prises de décision. Donc, en tenant compte aussi des normes qui existent au niveau des pays. Que la planification et la dotation également se fait donc en fonction de ces normes. Donc, et ainsi, sur la base de ça, plusieurs stratégies pouvaient être utilisées, soit le recrutement par l'État, donc puis recruter et qui met à la disposition du ministère de la Santé, mais également la contractualisation qui peut se faire donc via les collectivités territoriales qui ont des compétences décentralisées, mais aussi les partenaires techniques et financiers. J'ai donné l'exemple de la JICA, donc je peux donner l'exemple de la Banque mondiale ou d'autres partenaires qui appuient le ministère de la Santé via la contractualisation, mais aussi un problème de redéploiement infranational. Parce qu'au niveau interne également, si on voit qu'il y a un surplus, donc l'autorité peut prendre la décision donc, de procéder à un redéploiement. Donc, c'est toute une stratégie qu'on peut mettre en place si, évidemment, donc, on a des données fiables et on a également une base de prise de décision donc, basée sur des évidences.
Merci, Madame Kumba. I want to encourage those of you who are listening and speaking only English and not French to look in the discussion forum because we do have translations there and are capturing quite a bit. But Madame Kumba has been sharing about how investments in IRIS and capacity building at the decentralized levels have really helped them focus on this winning couple policy of redistributing and ensuring that there is an adequate distribution of at least one nurse and midwife for essential services across Senegal. So now I'm going to ask her what she has been doing when COVID has come along, when there have been, and other shocks. Donc, pardon, Madame Kumba, je voulais juste tenir compte des anglophones parmi nous. Donc, je vais vous demander maintenant, c'est très impressionnant de voir l'utilisation des données pour les politiques telles que les stratégies couple gagnant. Donc, qu'est-ce que vous aviez fait pour la prise de décision bien éclairée lors des chocs tels que la COVID-19 et d'autres?
En fait, peut-être que les prises de décision lors des chocs sur le plan ressources humaines, je prends l'exemple donc, des établissements publics de santé ou les hôpitaux. Les points focaux donc RH qui sont les chefs de service donc ressources humaines donc avaient pour charge vraiment d'investir sur l'organisation du travail des ressources humaines, mais également faire de telle sorte que les lignes d'action pour la protection du personnel également contre la maladie COVID-19 donc soient respectées. Développer des systèmes de motivation, par exemple, parce qu'avec la COVID, il fallait impérativement prendre des décisions avec le personnel qui doit rester et qui doit-on mettre en congé, par exemple. Donc, et là, c'est vraiment les ressources humaines avec l'administration donc, qui se réunissent pour dire que voici les catégories socio-professionnelles donc, qui doivent rester et voici donc les personnes donc, qu'on doit libérer donc, pendant un délai. Et sur la base de ça également, voir au niveau interne et même au niveau national, si on a les ressources nécessaires. L'exemple des médecins anesthésistes, des techniciens supérieurs en anesthésie est là au Sénégal avec la pandémie. Donc, nous nous sommes rendus compte que on a un gap, un déficit énorme donc, en médecins et techniciens supérieurs en anesthésie. Les médecins infectiologues également, les techniciens supérieurs en imagerie médicale. Donc, il fallait, avec ces responsables RH donc, et ces décideurs, voir où trouver ces personnels et comment donc faire pour les mettre au niveau des centres de traitement donc, qui existaient. Je crois que ce qui a justifié au Sénégal qu'à un certain moment, on devait contractualiser, donc on devait démarcher même des agents qui étaient dans le secteur du privé, donc les amener à faire des prestations donc via une motivation, un contrat de prestation donc au niveau des CTE qui étaient installés au niveau national. Et aussi, c'est avec le plan d'investissement sanitaire et la mobilisation des fonds nécessaires donc à la riposte également. C'est vraiment ces données, ces informations qui sont dans le logiciel, donc qui ont servi à son élaboration et qui ont servi également de base de mobilisation de fonds nécessaires.
Génial. Merci beaucoup, Madame Kumba. Je sais qu'on peut encore beaucoup parler de tout ce que vous avez fait et c'est très impressionnant. Nous allons continuer avec notre collègue du Mali, donc Monsieur Silla Abdoulaye, et nous allons revenir sur les discussions dans les questions-réponses pour aller plus loin, Inch'Allah.
Merci beaucoup.
Merci beaucoup. Donc, voici, bonjour Monsieur Silla, si vous êtes avec nous, si vous mettez votre appareil. Génial, voilà.
Bonjour, bonsoir Rachel.
Bonsoir.
Bonjour tout le monde.
Bonjour. Donc, merci beaucoup d'être avec nous. Oui. Alors, lorsque nous considérons comment augmenter la résilience des systèmes de santé au Mali, notamment, je comprends qu'il y a des considérations très importantes. Quel est le contexte et que faites-vous pour promouvoir la résilience des systèmes de santé?
OK. Merci bien, Rachel. Merci à tous les panélistes et merci aussi aux participants et surtout ceux qui ont organisé ces sessions pour nous permettre d'exposer un peu les efforts qu'on est en train de faire sur le terrain. Alors, le contexte du Mali est dominé par deux situations. Il y a l'insécurité du centre du Mali jusqu'au nord, qui couvre à peu près 60% du territoire. Et aussi, il y a une mauvaise répartition des ressources humaines sur le terrain. Donc, ces deux situations combinées menacent considérablement la couverture sanitaire au niveau d'un certain nombre de parties du Mali. Pour ce faire, le projet s'est immédiatement adapté aux réalités du terrain en incluant, en organisant la communauté pour être résilient à travers les organisations féminines, les organisations jeunes et même les leaders à tous les niveaux, associés aux agents de santé communautaires. Donc, nous avons pu renforcer la base de la pyramide sanitaire qui commençait au niveau SESCOM. Donc, à travers les efforts du projet, la base a été renforcée par l'implication que la communauté a s'organiser. Nous avons capacité à s'organiser pour détecter les besoins en santé et faire les références au niveau des centres de santé communautaire pour se procurer les soins. Aussi, nous avons amélioré aussi la qualité des données à travers la collecte à la base, la vérification et renseigner le système d'information sanitaire. Alors, le contexte COVID aussi, le système communautaire s'est adapté à travers le renforcement de capacités par rapport à la compréhension des messages, au respect des gestes barrières et à la surveillance épidémiologique à base communautaire. Donc, toutes ces actions ont permis à la communauté de réagir au contexte sécuritaire et aux déserts sanitaires qui s'installaient. Parce que l'insécurité grandissant, au début, ça ne menaçait pas les personnels de santé, mais il arrivait un moment où, au cours des évacuations sanitaires, le personnel avait même commencé à sauter sur les mines. Donc, ils ont pris peur. Le désert sanitaire avait commencé, mais avec l'amélioration de la demande, ça a influé positivement sur la rétention même du personnel. Rachel?
Oui, merci beaucoup. Excusez, c'était les aspects techniques. Merci beaucoup.
Ouais.
Donc, avec l'approche communautaire et tout ce que vous avez fait avec HRH 2030, quels étaient des résultats que cela avait donné au niveau des prestations de services?
Voilà, le premier résultat que ça a donné, c'est que bien vrai que le contexte sécuritaire ne facilitait pas l'utilisation des services, et pour autant, la stratégie a permis de maintenir cette utilisation. Parce que la communauté s'est finalement résolue à demander les soins. Donc, la demande des soins a été un bouffée d'oxygène pour motiver les prestataires à rester sur place. Ceci nous a permis de rehausser la qualité des accouchements assistés à travers l'utilisation des technologies de l'OMS, aussi d'améliorer l'adhésion aux normes de détection, de prise en charge des complications lors des grossesses, qui est même passé de 75% à 85%. Aussi, la planification familiale dans le postpartum s'est beaucoup améliorée parce que toute femme qui accouche dans le centre de santé a bénéficié des counseling et des services de paix. Et ce qu'il faut retenir aussi, c'est surtout la vaccination des enfants. Parce que même la logistique des vaccins, l'organisation de la logistique des vaccins et puis la mobilisation des vaccinateurs pour les stratégies avancées étaient entravées. Mais avec la résilience de la communauté pour rehausser la demande, ceci a permis à la communauté même de contribuer à la logistique des vaccins jusqu'au dernier village. Donc, ceci a fait que ce taux a évolué considérablement de 67% jusqu'à 77%. Voici en quelque sorte l'engagement de la communauté a permis vraiment l'amélioration de la couverture sanitaire. Aussi, face à tout ça, le désert sanitaire qui s'installait, donc nous a amené aussi à penser à développer un outil pour optimiser le temps. Puisque si nous n'avons pas assez de prestataires disponibles sur le terrain et que la demande augmente, il faudra vraiment penser à optimiser le temps de travail de chaque prestataire. C'est ainsi que nous avons commencé le développement et maintenant nous sommes même dans le test. Un outil qu'on a baptisé Avance PF, Avance SSP, la planification familiale et les soins de santé primaire. C'est tout grosso modo quand on renseigne cet outil avec les données réelles de réalisation de N-1 et par rapport au temps minimum de prise en charge d'un cas, l'outil est à mesure d'évaluer déjà le nombre de prestataires requis pour la tâche et aussi de nous proposer s'il y a excédent ou s'il y a un manque de prestataires ou bien si le prestataire requis est atteint. En jaune, vous allez voir par rapport à la qualification d'un prestataire et l'information qu'on donne à l'outil. Le jaune nous donne le nombre de prestataires requis. Le vert donne le prestataire disponible et ensuite la grise nous donne un peu l'excédent. En rouge, nous voyons que en ce moment, il y a un déficit en prestataire. C'est en ce moment ça, c'est une information qui permet aux gestionnaires de prendre une décision à savoir comment on peut combler le déficit avec un autre prestataire, qu'on peut renforcer la compétence pour qu'il puisse exécuter les tâches conformément aux normes.
Merci beaucoup, Sila. Donc, nous voyons concrètement au niveau des établissements, voici les données concrètes ou bien même les scénarios, n'est-ce pas, où nous pouvons voir les scénarios possibles, comment mieux répartir et faire l'allocation des tâches. En particulier. Super. Donc, en termes de soutien au personnel pour leur performance, parlons-nous de ce que vous faites pour la supervision au Mali.
OK. Très bonne question. En fait, si la demande augmente et qu'il y a moins de prestataires disponibles, là, le prestataire doit être efficace pour pouvoir répondre aux exigences et selon les normes. Nous avons constaté également que depuis 2012, où l'insécurité commençait à grandir du nord au centre, il y a des centres de santé qui ont fait 1 an, sinon 2 ans sans être supervisés. Alors qu'il a été démontré partout que la supervision est un outil essentiel pour maintenir et renforcer la capacité d'un prestataire à adhérer aux normes pour la satisfaction du client. Donc, c'est ainsi que nous avons réfléchi parce que, vu le contexte de l'insécurité, il y a aussi la raréfaction des ressources. Il y a la raréfaction des ressources, des problèmes logistiques et tout. Alors, nous avons pensé, puisque la couverture des réseaux s'est beaucoup améliorée et il y a Internet dans la majeure partie du pays, pourquoi ne pas essayer d'automatiser la supervision pour voir, même si un superviseur ne peut pas se déplacer chaque fois sur place, qu'il puisse établir un contact avec un agent de santé pour voir, sinon mesurer le niveau de connaissance de ce prestataire, mettre à jour ce prestataire par rapport à l'avancée de la science médicale. Donc, c'est ainsi que nous avons discuté avec la Direction générale de la santé et de l'hygiène publique du Mali à automatiser les outils de supervision dans le DHS2, qui est la plateforme utilisée pour le système d'information sanitaire. Donc, cette requête a été répondue favorablement par le ministère de la Santé à travers la Direction générale, qui a été très intéressant. Nous avons paramétrer l'ensemble des outils, la santé, la reproduction, la nutrition et même les soins essentiels de la communauté, qui permet à un superviseur de rentrer en contact avec un prestataire et qui s'évalue directement à travers Internet ou bien offline. Après, il cherche une connexion pour télécharger les données. Le superviseur, en un point, peut mesurer immédiatement la compétence du prestataire et faire des feedbacks. Aussi, au sein d'une équipe d'un centre de santé communautaire, ils peuvent faire l'auto-évaluation. Le directeur technique du centre, qui est le responsable du centre, peut superviser les autres agents par rapport à des contenus techniques bien déterminés. Et chaque agent aussi peut s'auto-évaluer toujours à travers la plateforme. Donc, chaque superviseur qui se connecte en temps réel peut savoir la performance d'un prestataire et peut rentrer en contact avec celui-ci pour faire des feedbacks selon les normes. Donc, c'était vraiment une recherche et dans les prochains jours déjà, la documentation va continuer.
Merci beaucoup, Monsieur Silla. Now, for those of you listening in English, I just want to highlight this really exciting innovation in Mali with regards to digitizing and integrating supervision checklists at the national level into existing health information systems, notably DHIS2, so that supervisors and performance managers can have access to supervision results in real time, or at least during these quarterly review meetings when they would be reviewing data in general. And I think this option for distance supervision or self-assessment as part of distance supervision is really important. And I hope that we can find more opportunities and to continue to research and see what the impact and effect of supervision at the distance level is, remote supervision. Excellent. Nous allons avancer dans la session questions-réponses pour vous, Madame Kumba et Monsieur Silla. Donc, nous avons une première question d'une participante, d'un participant pour comprendre. C'est pour vous, Madame Kumba, pour comprendre comment IRIS peut soutenir les analyses du genre du personnel de santé. Quels sont les outils ou les approches analytiques requis pour faire l'analyse genre?
Merci Rachel. Je crois que par rapport à la question, ça dépend des variables qui sont paramétrées dans le logiciel. Parce qu'il faudrait que, actuellement, avec l'approche genre, que l'ensemble de nos outils et ressources humaines soient sensibles donc, au genre. Et pour cela, il faudrait démarrer par la stratification. Donc, le fait, par exemple, de faire la répartition par sexe, par âge, mais également cette répartition par statut, la répartition également, voir s'il y a un handicap, le niveau d'handicap, par exemple, de l'agent, et aussi la prise en compte différenciée des besoins, parce que des hommes et des femmes, surtout par rapport à la mobilité. Donc, il faudrait également que ces que ces éléments donc, soient paramétrés dans le logiciel. En tout cas, dans le logiciel du Sénégal, nous avons tenu en compte donc, plusieurs paramètres genre, et nous allons nous projeter dans quelques jours parce qu'on l'a inscrit dans le nouveau plan national de développement des ressources humaines à la révision du logiciel IRIS, donc en le rendant plus sensible au genre. Parce qu'il faudrait qu'on fasse donc qu'on ait ces informations et qu'on puisse avoir des tableaux de bord, sur cette thématique.
Okay, so to translate in English quickly, she's confirming that the system has been set up so that gender, age, employment status, and all of the others are available for some disaggregated analysis, and that it's quite important, specifically as you're looking at the mobility and the way that health workers move around. Donc, je vais encore creuser. Madame Kumba, il y a une autre question pour vous par rapport notamment peut-être le mouvement de personnel entre le secteur privé et le secteur public. Est-ce que votre système comprend, est-ce qu'il y a les données des personnels de santé dans le secteur privé et quelle est la manière que vous arrivez à les traquer?
OK. Bon, actuellement, nous n'avons pas les données du secteur privé dans le logiciel Irish. Donc, c'est une option qu'on a envisagée et qu'on a testé même, que ce soit le secteur privé, que ce soit le secteur communautaire, parce qu'on a des agents de santé communautaires qui interviennent. Mais quand on a voulu tester avec le secteur privé, nous nous sommes rendus compte que nous allons rendre notre base aveugle dans le sens qu'il y a des doublons. Dans le secteur privé, on ne parle que des catégories. On dit que au niveau de cette clinique, on a 2 médecins, 5 sages-femmes et 3 infirmiers. Et ces sages-femmes, infirmiers et médecins ne sont pas tous des permanents. Il y a des permanents, peut-être 2 ou 3 permanents, mais tout le reste, c'est des prestataires. Et ces prestataires sont déjà comptés dans le logiciel parce qu'ils sont dans le public. De ce fait, si on intègre pêle-mêle donc les informations du secteur privé, donc on a des doublons. Et on risque donc de rendre aveugle, dire que le Sénégal ou peut-être telle région n'a pas de déficit alors qu'il y a un déficit criard. Mais il fallait donc prendre l'option de créer 2 interfaces, l'interface privée et l'interface communautaire. Donc c'est vraiment sur ça que nous allons démarrer donc les travaux pour avoir donc 3 interfaces en fait, le public avec Irish Manage, mais également l'interface privée et l'interface communautaire.
Wow, merci. Ça doit être un grand travail. Donc, bon courage et bonne continuation. So the response to this question of how do you manage mobility of both the public and private sector within Senegal System, the challenge that Madame Kumba shared is that you will often see the same health worker who may have a different status and may be moving in between both the public and private sector. So there is a lot that you need to manage. In addition, the community level is not yet fully captured within their national system. So both the private sector and the integration of people who may wear multiple hats within the health system, as well as the community level, are some areas where they'll continue to explore. Merci beaucoup, Madame Kumba. Pour vous, Monsieur Silla, nous avons une question pour comprendre le profil des superviseurs au niveau de, lorsque vous avez parlé de la supervision. Quel est le profil, quelles sont leurs compétences et capacités?
Okay. Merci bien. Alors, par profil, comprenons que les superviseurs, généralement, c'est des médecins, les techniciens supérieurs sages-femmes, les techniciens supérieurs infirmiers d'État, et puis les spécialistes en biologie et les techniciens supérieurs en hygiène, assainissement, qui ont atteint un certain niveau d'expérience dans le système de santé, qui ont un certain nombre d'expériences dans le système de santé et qui occupent généralement les postes de responsabilité. Donc, ils sont aussi formateurs dans beaucoup de domaines de la santé. Donc, voici un peu les critères de choix de ces superviseurs qui sont à même à pouvoir renforcer la capacité de chaque élément de la pyramide sanitaire.
Merci beaucoup. Merci à vous deux. So the question was in terms of the profile of supervisors in Mali, and Sila responded that they're primarily medical doctors, but they have received training across the health system in several areas, ainsi que dans l'informatique pour ces superviseurs.
Oui, dans la plupart des cas, ces superviseurs ont beaucoup d'expérience dans l'informatique parce qu'ils gèrent également des départements. Ils ont eu des formations en informatique dans le passé.
Merci beaucoup. I wish that we could continue further, but I'm going to pass it now over to my colleague Leah McManus, who will bring us to the third round, including the interactive case studies. Over to you, Leah.
Great. Hi, everyone. Wonderful. So what an incredible discussion we've been having here today. We've learned a lot over the past hour and a half about use of health workforce data and evidence to build resilient health systems. And now we really want to open up the discussion further and apply our learnings. So next slide, please. So I'm going to read a case study to you all, and then using the polling feature that you can either see at the top of your screen or on the right of your screen, we are going to ask you to respond to a question. After you respond, tell us more in the discussion forum. We really want to hear from you on how you, on why you chose that response. Normally we would be together in a room, so this is our way of wanting to learn more from you and have a bit of a discussion and dialogue. And once we have the responses from you, we're going to hear more from our panelists. So please feel free to continue to use the Q&A box. So here is our situation. The Pineapple Republic is planning an urgent vaccine distribution campaign, prioritizing underserved populations, including pregnant women and children, urban slums, the elderly, and migrants. Throughout this campaign, the Pineapple Republic is committed to delivering essential healthcare for all of its people. However, historically, it has been challenged to produce more health workers, to equitably distribute them and retain the existing health workforce, and to expand decent paying health sector jobs. We need to support the Pineapple Republic to design an evidence-based approach to develop and strengthen the health workforce to successfully distribute the vaccine while ensuring the continuity of essential services. Next slide. So here's our first question. What health labor market information would you use to inform the vaccine campaign planning? So again, what health labor market information would you use to inform the vaccine campaign planning? So I'm going to release the poll. I'm going to release the poll. Are you guys seeing that?
It's live on my side, yep.
Okay, great, thanks. Rachel, I might need you to manage it because I'm not seeing a change on my side.
No problem.
Sorry, everyone. Okay, what health labor market information would you use to inform the vaccine campaign planning? So select one of these options. A, roster of health professional training institutions and projected graduates by type. B, a human resource information system with real-time mapping on location of health workers. C, registry of professional council or association members, including data on the private sector. D, a list of community health workers, which is managed by the local government. Or E, other, and explain more in the discussion forum. Once you've answered, tell us why in the discussion forum. So give us all a minute here.
So what I'm seeing so far is a lot of folks are selecting the human resource information system. A number are looking and suggesting that the registry of professional council and association members is important, as well as the list of community health workers. And as we had noted in this previous section, community health workers have been professionalized in some settings, but the extent to which they may be captured in the broader health workforce information system remains to be seen. So we're seeing some dueling between the human resource info system and then understanding what that roster of community health workers might look like.
Interesting. Yeah, so I think that what we're getting here is that we really want to understand where our active health workforce is so that we would be able to leverage them. Great. So maybe we can take a second. I'm not seeing any comments in the discussion forum, but maybe what we can do is see if any of our panelists would like to comment on that. Maybe Taufik, would you like to comment on this question and how Indonesia might address this?
Thanks, Leah. Yeah, for question number 1. Yeah, we have a data and consists of many eligibility and capacity, such as the membership of the organizational professionals, and we have data regarding like education backgrounds, such as the health promotion, for examples, and volunteer in many levels. So that's why I think the information system is very crucial and very important to the campaigns and planning as well.
Great. Thank you. Maybe I will also ask our colleague Kasum if you have any thoughts on this question you'd like to share. Kasum? Can we unmute Kasum?
Hello?
Okay, there you are. Yeah, we just wanted to see if you had any comments on this.
Yes, thank you very much. I think what would be important in this. Is it okay?
Yes, we can see you.
Okay. What would be important in this is 2 things. One, information about the needs, and the other information about the labor market itself. And for all of these, I think the questions that are here and then these would be important. So, of course, the Rostov Health Professional Training Institution will give you some of the projections. It will help you to anticipate how many people you would have in the future. But it will be important that your basis is your current staff and how many people from your current staff you can redeploy to the COVID response and to the COVID vaccine. And that's central to this answer. So it's a combination of some of these that are here. The registry is important, the information system is important, but these are some of the sources. You need to have the exact data also related to that.
Great, thank you. That's it. Great. Okay, so I think we'll go to the next poll. All right, here's our second question. Wonderful, I'm seeing it now. So what priority strategy would you use to engage and train the most appropriate types of health workers to distribute the vaccine? So select one of these. A, an e-learning platform to rapidly train frontline health workers on the campaign and to integrate the vaccine into primary care. B, a smartphone application for vaccinators to use for reporting on vaccination progress as a job aid, and for supervisors to provide performance feedback. C, an incentive pay scheme to motivate the private sector to be involved in this vaccine campaign. And then D, engagement of a youth brigade of community-based vaccinators to support rollout of the campaign. Or of course, other, and definitely provide us with more thoughts in the discussion forum. So I'll give you all a second for that. And any of our panelists, start thinking if you want to respond to this. So, même Monsieur Silla ou Madame Kumba, si vous avez des commentaires, n'hésitez pas.
Ok, oui, merci bien. Moi, j'avais levé la main depuis la première discussion. Pour la première question, je préconisais de voir avec la communauté s'il y a la disponibilité des volontaires. Ça, c'est pour la première question. Il peut y avoir des volontaires qui sont disponibles, qui peuvent aider à la mise en œuvre des activités de vaccination. Alors, par rapport à la stratégie, moi, ma proposition, c'est de toujours voir avec communauté, s'ils arrivent à identifier un certain nombre de volontaires, de voir comment utiliser ces volontaires et comment ils peuvent les rémunérer à travers la communauté elle-même. Les travaux champêtres et autres choses peuvent être utilisés pour rémunérer les volontaires identifiés pour aider à la mise en œuvre de la stratégie. Voilà, voici mes deux propositions pour les deux questions.
Merci, merci, monsieur. So, first, he's really building on the two questions in our case study, and he said, for the first question, he would tap into volunteer resources to see about helping with the vaccine campaign, and then following that, his strategy would be looking at how to remunerate these volunteers to be able to participate in this campaign. It seems like here in our poll, we have about the higher majority of people would say the e-learning platform. And that makes sense, right? Because that is a way we can give access to more information to people, even at the furthest reaches. So, and that's, it's going up. And then secondly, we're hearing about a smartphone application that would be able to support the health workers is a job aid in the vaccine campaign, and then also to report on progress and working with this in providing supervisory support. So for this, I think Dr. Ruth, I don't know if you would like to comment on this, considering the e-learning work that's been going on in the Philippines.
Thank you, Leah. So I think what I can share in the Philippines, we developed and we're currently utilizing the e-learning platform for many of the courses, especially during this COVID-19. And one advantage for it is that you'll be able to engage like 1,000 learners at the same time. They can do it anytime, anywhere they are. They can print their certificates, so it would be easy to credential who among them will be qualified to deliver the vaccines because they have some proof, the certificate. And I guess because it's free if it's government funded, so it provides more access to the health workers, including the ones in the community. So I think that's all. Thank you, Leah.
Thanks. Great. Yeah, great to hear firsthand experience and how you're using e-learning actively right now. So I'm just going to look in the discussion really quick. So Etienne is saying, depending on the countries and context, the success of the vaccination campaign lies in the community. Yes, he's saying that we need to build the strategy with the local leaders and link them with community health centers, and that's absolutely critical. And I think that has a lot to go back to our sort of our session theme and sort of our the conference theme about building resilient health systems and reimagining health systems. So that's really great. Thank you for bringing that up. And Ismaila is commenting very accurately that definitely the training of the vaccine depends on the method of the vaccination, the risk profile. And these are great points that he's making in the comment because with this, we'll be able to make sure that we're maintaining quality of provision of services. That's absolutely critical to any vaccine that or to any way that we're going to be doing a sort of campaign while trying to maintain essential services. Rachel, do you have any comment?
Sure, I can just highlight, gathering some of the discussion, that, this first piece that you have done really well to answer is, when you understand what the nature is of the vaccine, what sorts of skills and competencies would be required of the health workforce to effectively deploy it, to then think about what would be the most appropriate ways to, rapidly skill up the health workers that would be the most appropriate. So that could be, we sort of talked about, well, if the HRIS doesn't have community-based workers, but it would be appropriate to train and deploy some of those workers how can you connect with them? And I like Sila's point of really involving the community from the start in identifying who those community health workers or volunteers may be. And of course, where community health workers have been professionalized, and if per the WHO CHW guideline, they have been selected from the community, they are already trusted, because when we're looking at the hardest to reach populations, those who may be the most underserved, the level of engagement they have with the health system may be the least. And so thinking not just about some of the clinical or semi-clinical and health system competencies that are required, but also some of those interpersonal, cultural and linguistic competencies that will be necessary. Over to you.
Yeah, Kasum, do you want to weigh in? Can we unmute him? Hold on one second, you're still muted. Can we unmute Kasum? Okay.
Can you hear me?
Yes.
I just wanted to say that we have to put everything in context. First, for this COVID vaccine, it will be the biggest vaccination campaign ever in world history. Because the current scenario are saying, let's try to immunize 3% and then 17% of the population. And this is, we are talking about billions of people. And the biggest campaign is 100 million so far also. So this requires that you do a proper assessment of your need and your system's capacity to say, I'm going partly to redeploy some of the workers for the COVID vaccine, but we need to scale up. And this is where I joined Rachel in her book. We need to scale up, and we need to scale up taking into account country context, but also taking into account the communities. There are a number of initiatives like the rural pipeline, where people are hired from the rural area and trained in the rural area and then deploy in the rural area to maintain really the essential services, community health workers, and some others, those people who can be trained quickly to support. But if we want to rely only on the existing staff, in many countries, this will take years to be completed. Just in addition to what the colleagues have said. Thank you.
Yeah, absolutely. Thank you. Yeah, and I think this is something that obviously is coming for all of us soon. So taking this advice and thinking through it is really important. So let's go really quick to one last question. Let me start the poll for you all. Great. So what will be your main health workforce considerations in carrying out this campaign to ensure the continuity of essential health services? So thinking about that. So go ahead and select all that you agree with, but try and do the ones you think are the most important, because I'm sure you might be able to make a case for all. So first is workload pressure of current primary healthcare staff for awareness on capacity of this staff to absorb these additional tasks. Optimizing task allocation at the facility level to be adaptive and support effective service integration, including at the community level. Multisectoral networks, including the private sector, to diversify campaign approaches and sustain outreach. Routine performance support to ensure quality in the campaign and essential services. And E, promoting women's leadership and gender equity to bolster workforce diversity, and of course other more, and explain more in the discussion forum. So I'll give you all a second. On my side, it's going like this. Let's see what we all think. Maybe while we're waiting for those to come through, I will ask Madame Kumba, voudriez-vous partager votre avis, même si c'est pas pour les autres questions?
Oui, en fait, j'écrivais dans le chat qu'il y a une combinaison, qu'il faudrait prendre en compte donc la combinaison de plusieurs facteurs, surtout par rapport à l'identification des obstacles ou des barrières donc, qui peuvent faire échouer cette campagne. Donc, il fallait vraiment combiner plusieurs options, mais aussi intégrer la communauté donc, dans la vaccination, parce que des fois, donc, il y a des perceptions ou des réalités culturelles donc, qui poussent certains à accepter ou à rejeter donc, la vaccination. Et le fait également de vouloir utiliser le e-learning, je pense que c'est surtout dans le souci d'assurer la continuité des services, parce qu'on sait que selon le cas, donc il y a un déficit notoire donc de ressources humaines. Donc s'il faille fermer la structure, donc les structures et aller donc former les agents, peut-être qu'il y a une rupture de continuité de service. Je crois que les e-learning, les smartphones également peuvent être utilisés, mais il faudrait aussi donc assurer cette supervision in situ de l'administration des vaccins, parce qu'il y a des règles donc dans l'administration des vaccins. On ne peut pas nous contenter uniquement donc pour des formations en ligne donc sur smartphone et autres. Donc il faudrait que même si c'est une petite équipe, qu'on fasse donc cette supervision in situ donc de cette vaccination. Les considérations générales donc en ressources humaines, la charge de travail donc voire est importante. Donc qui doit dispenser et comment la stratégie, si c'est une stratégie mobile, donc si c'est l'infirmier ou bien tout le personnel qui doit se déplacer, donc qui doit assurer la continuité de service au niveau de la structure. Donc si c'est la communauté également, donc on peut voir donc par rapport à cette charge de travail combien de vaccins, combien de cas de contact donc pouvons-nous avoir, mais surtout la multisectorialité. Donc il faudrait que vraiment que tous les secteurs, que ce soit le public mais également le secteur privé, donc puissent participer à cette campagne et que des supports aussi donc soient utilisés, donc des supports de communication, des supports qui nous permettent de prendre des décisions, même si c'est des bases de données donc ou routinières qu'on a sur la main, donc des supports qui nous permettent de prendre des décisions soient utilisés. Et le leadership également, il faudrait qu'on développe donc ce leadership, surtout des femmes, parce que c'est une vaccination qui est à l'endroit destiné aux femmes et aux enfants. Donc le fait donc d'avoir chez nous donc on a les groupements féminins, donc d'intégrer ces groupements féminins, donc les femmes donc qui participent au plaidoyer pour l'acceptation de cette vaccination également est important pour moi.
Magnifique, merci. Yeah, I think what Madame Kumba is outlining for us is just how important a comprehensive approach is needed for such an undertaking. She, in her first part, when she was talking about what would be the main interventions that would be needed, she believes that e-learning and smartphone would be definitely helpful in getting out the training and for documentation or for use during the vaccine, but supervision is really still needed at the end of the day to ensure quality, the quality provision of services. And then in addition, when you're even if you're talking about using nurses or community health workers, you know, no matter who you're looking at considering using, we need to be looking at health service delivery data and supply chain data all together to make sure that we're developing an approach that doesn't just take into how many people are there, but what their workload is going to be able to provide this vaccine campaign. And then finally, one of the last points she mentioned was that integration into women's leadership groups like they have in Senegal is also extremely important to this into this campaign. And I think that's a really interesting point we haven't explored very much. But what are the community groups that we can leverage? What are the gender considerations in our countries that we want to be taking into consideration along with health workforce data to be able to really optimize this approach? Great, yeah. Rachel, did you want to add anything to that? Oh, you're on mute.
There we go. No, I think that's a great summary. I think there are so many different considerations. I don't know if there are any final comments from any of our very esteemed discussants before we continue on.
Kelly, do you want to, maybe we can have you jump in here. Can we unmute Kelly?
Yeah, I think I'm unmuted.
Okay, great.
Great, thanks. So if I similarly for all of your questions probably would have selected all of the above, but I think if I had to pick one for this one, I do think that the multisectoral networks, including the private sector, especially if we were trying to distribute vaccines and ensure the continuity of services at the same time, we need to recognize that over 50% of services are delivered in the private sector, and really they are an important partner, and using the private sector to include both for-profit and not-for-profit, faith-based, civil society, private sector, but really to look out for how better sharing agreements between public and private sector can be worked out to ensure that as a society, we can both deliver vaccines and maintain the continuity of essential services, and that might mean shifting locus of support and control between those public and private sectors. So the stronger the networks, I think the better able countries can be to really scale it up and do the vaccine delivery really quickly while also maintaining services.
Yes, that's great. Thank you. Great. So thank you all for this discussion. As we can see, there's no one size fit all, and really we actually think we want as many as possible, as many interventions as possible. But it's really clear that we understand that taking a data-driven approach to health workforce decision-making is key to building this resilient health system. So thank you all for participating in this. We try our best to be interactive during these virtual meetings, so we appreciate it, and great feedback, great discussion. This is wonderful. Thank you. Over to you, Rachel.
Great. Thanks, Leah. Merci à vous tous et toutes d'être avec nous. Thank you all for being with us this morning. Just briefly, some closing remarks. Reflecting back across some of those 5 attributes of a resilient health system, when we think about what makes a health system resilient through its self-regulation, we think about some of those foundational principles of governance, including data governance and security. Both our Philippines and Senegalese colleagues had mentioned, the importance of data security and the approach for sharing. When we think about the integration of health workforce information in the system, we've talked a lot about the important users and what sorts of behaviors and competencies that they need to take this data and include it in their routine management approaches and operations. We didn't get into details on the role of digital, but it was really omnipresent across a lot of these discussions that we need to look at the principles for digital development and ensure that there is integration and there's human health worker-based design and consultation and involvement, not just in the policies and in the development of these innovations, but in how they're ultimately operationalized and then continue to be improved upon. When we think about health systems resilience in terms of diversity, our discussants talked a lot about the key role of community. People drive health systems. I think about community as the little p private sector, that they represent an important contribution to the health system. And the more that we can involve communities and as decision makers for their own health, the better that we will be taking steps to social justice and more patient and community-centered healthcare. As Kelly had just mentioned, the role of the private sector as a means for sustaining and financing and ensuring the extension and the reach of all services is really paramount. When we think about awareness, using health workforce information can improve the awareness, the ability of any country or system to respond to a challenge. If you don't have the right people with the right skills in the right places, then it can be really hard. And I think also awareness of, as some of our participants had highlighted, the importance of taking gender analyses to the workforce to understand why things are working or what sorts of considerations may need to be in place. When we think about health system adaptiveness, that is in terms of, what is its flexibility? What is the information it has to then be able to pivot and respond to the ways that resources are allocated? And having real-time data and information available, decision makers can be much more adaptive. So in closing, just want to highlight that when we speak of health workforce investments, many of our discussants had spoken of, a decade plus of planning and systems getting in place. But these investments are really triple wins. And they're triple wins in terms of helping to better support the health workforce, to make sure that there is decent and safe employment, that there's a reasonable workload, that there is planning for sustained remuneration across the health workforce for the work that they should be paid for and so forth. but also ultimately for the health system, so that they know which people are in place and how they can be mobilized to effectuate the health system's actions. And then ultimately, the third win is, of course, for the people. When you have the health workforce well prepared, well protected, and well supported in a more functional, more resilient health system, that means that the people will benefit. So when we think of these investments, remember the triple win for the workers, the system, and for ultimately the people. So I thank you so much for your time. Enjoy the rest of this conference, and look forward to continuing the discussion with all of you. And would also, hold on a second, would be remiss if I didn't mention, you can access a number of the resources that we had included within the discussion chat at this bit.ly. Check out the HRH 2030 program.org website, and also encourage you to check out the poster of HRH 2030's work more on Senegal and the role of gender within the health and social service sectors. Thank you so much. Terima kasih, merci. Have a wonderful day.